Is anyone on from the American Cancer Society? Because I don't want to steal their thunder.
Steal all the thunder you need. How about that? We're live now. Yay for us. Welcome to our community conversations presented by the Ministers Alliance of Rhode Island. My name is Lori Smalls. It's such an honor to be here today with these amazing people who are doing wonderful, fantastic things in the field of cancer awareness and treatment. As the Ministers Alliance, we have been committed to these community conversations. We believe fully and firmly that knowledge is power, and as much knowledge as we can gain, we know that we're able to demystify some of the stigmas around even getting tested for cancer. Our initiative is really focused on screenings, or as we heard a doctor refer, check. We want to continue to check with our physicians, check with our family history. We're going to be talking about that today. Miss Marcy Beeston is here to give us some wonderful information about genetics. We also have Dr. Barry Fabius with us. We're very excited. Pastor Pam from the Ministers Alliance of Rhode Island Ministers Alliance, and also Alicia Fernandez from United Healthcare. So excited as we're continuing these conversations. Each time we find out something new, we found out something new that we didn't know, especially regarding testing. We are really emphasizing the 4 screenable cancers that we can talk about: breast cancer, cervical cancer, colorectal cancer, lung cancer. We want to make sure that if you all are not seeing your doctor regularly, please do so. Talking about your family history, the Department of Health has a wonderful tool called the Family History Tool that we'll be showing later on to really be able to have this wonderful discussion with your children, your nieces, your nephews, your brothers, your sisters, your grandchildren. A wonderful document to be able to take to your doctor to say, in my family, these are the history of illnesses, hypertension, diabetes, cancer. Oftentimes in the faith community, we don't even like to say the word cancer, but we understand that the diagnosis of cancer, usually the screening is the first step to healing. And so again, we want to really emphasize, if you have not, talk to your doctor. If you don't have a doctor, please reach out to us. Alicia is here for United Healthcare. We want to also re-emphasize, please do not let lack of insurance coverage be a reason why you do not see a physician. Certainly talk to your pastor. I'm a pastor. I love my people to talk to me, but I'm not a doctor. And I don't play one on TV. So the most I can do for you is pray with you, but your doctor really can give you the insight that you need relative to treatment. And again, if you've even just heard the diagnosis of cancer, we want you to know that cancer, that diagnosis, does not have to be fatal. What we've heard from the wonderful content experts, subject matter experts, early detection is really the first step in healing. And so as we begin this conversation, can we have Alicia, can you just give us a greeting from United Healthcare, if you don't mind, please and thank you.
Hello, everybody. How are you today? I'm happy to be here from United Healthcare. I do community outreach along with my partner, Panita Pevele. So we're out in the field every day trying to spread the word about the importance of having health coverage, making sure that it's active, and then also the importance of these screenings. Every tabling we're doing, we're bringing these flyers and trying to get the word out in the community to make sure that we get everybody out there to do their screenings, to stay healthy. If there's any issues with your healthcare, please feel free to reach out to me. I'll share my contact information in the chat. If you just have any questions on how to get coverage, on where to go to get a screening, please feel free to reach out to us. We're here to help you with that and would be happy to assist.
Thank you so very much.
You're welcome.
We would now like Dr. Barry Fabius, if you could give us all of your thunder. We appreciate it.
Got it. Well, first, I want to start with a thank you for giving me the opportunity to continue to join you on these community conversations, which I believe are vital. And hopefully we're getting the word out so that people will go and get their screenings done in accordance to the guidelines and in accordance to their primary care physician, so that we can hopefully prevent cancer from occurring. I am, again, Barry Fabius. I'm the Chief Medical Officer for United Healthcare's Community and State Program in Rhode Island. And I have the great opportunity of working with Alicia. So I can thank her at the same time for everything she does. So I'm going to start with the fact that I'm old. So that gives me hopefully a little bit of wisdom along the way. I was in practice before joining United Healthcare. I am a geriatrician. I take care of older adults. I was in practice for 24 years. I was the head of geriatrics departments for 2 different health systems before joining United Healthcare. And I would say in those 24 years, a few of the saddest cases that I had to care for were those individuals who did not do their preventive screening for cancer and showed up in my office with late stage cancer. And they waited till they were symptomatic, until they had abdominal pain, until they had GI bleeding, until a mass was actually palpable and sometimes even breaking through the skin. So I'm here in an effort to tell you that that is really not the pathway that any of us want to proceed, and that that pathway is preventable. And the way that we prevent it is by doing the proper screening. We've had a lot of individuals come to speak on some of these community conversations who were generous enough to tell us about their journey in their cancer pathway. And so I also want to add that catching cancers, not only preventing cancers, but catching cancers early are sometimes curable and sometimes simple cures. So the example that I've used is, the person who's had a colon mass, that's found on colonoscopy when it's very tiny. Sometimes they can just use what's called a snare during the colonoscopy and take that mass and then tell you that you're cured, because it's not what we would call an invasive tumor at that point, and that they get all of it. And even better is when they snare that mass when it's just what we call a polyp, or it's not even become a cancer yet. So the earlier we catch it, the better. And even better than that is that we prevent it entirely. So I want to empower you to utilize a couple of different sites. And again, am I able to steal the screen here? I'm going to
Yes.
Okay.
You see a little green box at the bottom of your screen.
Okay. Tell me if you're seeing my screen. Yep, great. Okay, so the one that I like to start with is United States Preventive Services Task Force. It's up here in the left corner, the United States Preventive Services Task Force, sometimes referred to as the USPSTF. So the USPSTF makes recommendations, as you can see in this block. And I like to look at the published recommendations for cancer, and it will lead you to this site. And here you could find out, what you should do, let's say, to prevent some of these common cancers. And one of them I'm going to go to is colon cancer screening. So then it tells you that the USPSTF recommends screening for colon cancer in all adults aged 50 to 75. And if you have, certainly if you have a history of cancer, or if you're more concerned, even starting, here you can see in the second line, starting at 45 is now recommended. So if you want to be cautious, you can err on the side of 45. But again, all these recommendations should be discussed with your primary care physician as you make these decisions. Sometimes we even want you to start earlier. If you had a relative who had cancer at a very young age, then we might want you to start younger than the age that that person had the cancer. So these screening tools that you can look at serve as kind of a springboard or launch point for a discussion with your primary care physician to determine what's right for you. But I do like the USPSTF as a resource where you can look again for how frequently to do your mammography, your cervical cancer screening, prostate cancer screening. So you could look up any of the screens that you're interested in. The other one that's a great site is the American Cancer Society. And so here it actually breaks it down into what you should be doing for cancer screening at different ages. And so, for example, 25 to 39, cervical cancer screening, 40 to 49, we're going to start recommending breast cancer, cervical cancer, colorectal, and to discuss with your physician prostate cancer screening. Prostate cancer screening, I will say, is a little more complex and really is worthy of a discussion with your primary care physician as to when and if to start prostate cancer screening. And then again, in ages 50 and above, similar to the 40 to 49, with the addition of lung cancer screening in individuals who have a history of smoking or are currently smoking. So those two sites, I think, are great in terms of, again, you can even, look at these or print them out and use them as a beginning for a discussion with your primary care physician regarding what you should do and how frequently you should get your cancer screening done for each of these. And I'm hopeful that folks, to walk away with the idea that being aggressive about prevention is the best way to prevent cancers from occurring and having to deal with them. But even if you do have them, I do want to let folks know that treatments are getting much better every year. We have a lot more of what we call targeted therapies so that we can go right after that tumor without damaging other parts of the body or other tissue. So that process is ongoing and continues to improve every year. And with that, I'll hand it back over to you, Dorothy, and then we'll go, unless anyone has any questions.
I do have a question. So each time you talk, I really do get something wonderful and new and exciting. But you said something about when you began to talk about with older people, by the time they come to see you, oftentimes something has broken through the skin. Can you elaborate on that? Or is there something that we should be saying to our elders?
Yeah, I mean, it's for me, it's always a sad scenario if that is the case, because then I know that the tumor's, grown significantly in an effort to, if it's coming through the skin, particularly like breast cancers. Unfortunately, I did see some breast cancers which had broken through the skin, and that means that they had gotten to a significant size. And it was going to be much more involved, in terms of the treatment plan that was necessary for that. And it usually means that if the mass is that large, that it's probably metastasized. It's probably spread to other parts of the body. Again, that's why you certainly don't want to wait for that. Um, and I had another case where it was actually a head and neck cancer as well, which had broken through the skin. So um, that, I think sometimes it's because the individual is so fearful of the treatment that they wait and wait and wait. But I can tell you that it makes it a lot more difficult, certainly, to treat and to treat successfully if you wait too long. So the earlier, the easier, and the more likely that we're going to be able to treat it or cure it.
And I thank you for saying that part about waiting and waiting and waiting. Oftentimes in our community, we, especially older people, believe you only go to the doctor if there's an emergency, right? Don't bother the doctor with these little things. Let me put some Vicks on it and it'll go away or something like like that. And we're really trying to enforce the concept that your body best, and so when something's not working the way that it normally works, that you really should see a doctor about it. But if you're saying to us again, if there's some lumps or bumps or bruises that I added the bruises myself, or lumps or bumps that are not common, we should be talking to our doctor about that as well.
Exactly. And the beauty of doing the preventive screens is that's when you're asymptomatic, meaning that you have no symptoms at all. And if we can see something in that early stage before you have any symptoms at all, we're much more likely to be able to treat or cure. Certainly more likely to cure it, and certainly could treat it early. So I guess if anything, I'd rather you not be symptomatic at all, right? So that you've gone and done these preventive screens, and if we do catch something, we catch it very, very early.
Thank you so much for that, because oftentimes we don't share our information with our families. And I'm going to share a tool that we have been encouraging people to use. It's called My Family's Health Portrait, that is provided by the Rhode Island Department of Health. It's a actual piece of paper that we'll be happy to bring to any location that anyone would like for us as the Ministers Alliance to bring, really just about talking about your family's health portrait: grandmother, great-grandmother, grandfather, great-grandfather, father, mother, aunt, siblings, because as Marcy will come, who's our genetic counselor, these things, and tell us some wonderful information. These things are important, and you will see at the bottom of the form there's some abbreviations about some of the diagnoses that maybe sometimes the people in our family would have, including diabetes, kidney disease, arthritis, heart disease, mental illness, and May is Mental Health Awareness Month. Asthma, high blood pressure, osteoporosis, cancer, high cholesterol, and stroke. Those are the things that are absolutely important, and we would love for you to take this at your next family gathering and use this as an opportunity to have further discussion. Pastor Pam, you have your hand up.
Yes, this is for Dr. Fabius. He had just given us a website to go on. Also, too, I did not see it, but maybe I need to get on it to get more information. But what I wanted to ask was, with these guidelines, and we go on, do these screenings on this website, does it tell us how often we should have these screenings? There are some where you go every year, or for example, the colonoscopy is every 10, or if they don't find anything. So on this website, can you explain that to let us know how often we need to do these screenings?
You're exactly right. So on these sites, you can click on those particular screens, and it will lead you to the intervals that are recommended as well. Sometimes the intervals are determined by your own family history and health status. So I would say again that we use these just as guidelines, not as, laws written in stone, so that everything should be discussed with your primary care physician to make the appropriate decision on how rapidly and how long that interval should be. But the guidelines are there. If you click on the USPSTF screening tools.
Thank you. Thank you. Because
Sure.
we do need to know, they probably have one screening and they say, I'm good, and they don't want to go back. And for a person that went through breast cancer, I did have mammograms every year. And one of my sayings is you never know what's going to happen in 1 year. I had great mammograms, no problems, until one was 1 year, the year of 2010 was different from 2009. And that is where my road to recovery. But since it was every year and I went every year, these screenings do help to detect before it is out of control. So that is why I wanted to know, and we want to make sure that everybody knows about the intervals of your screenings. Check with your doctor to see if it's every year or every 10 years or every 5, so that you can be ahead of the game.
Excellent point, and thank you for sharing that. I think you're right. We do that progressive interval repeated screening because you never know when it's going to occur, and obviously everything has a starting point somewhere, and we want to get it right at that starting point.
That's right. Thank you,
And
Dr. Fabius.
and that is why it's important to fill out that family history portrait so that you can, when you go to your doctor and they ask, is there a history of this in your family? It's often good to know, is there a history of this? So with that, we're going to turn it over to Marcy Beeston, who is a genetic counselor. Again, we're going to learn so much today. We're going to walk away with knowledge, but we want you to take that knowledge and put it into action. See your doctor. Please hear what Dr. Fabius already said. Early, early, early is better. See your doctor. Miss Marcy.
Thank you. I'm just going to share my screen for you. Can everybody see this? Okay. All right. So
Yes.
my name, as she said, is Marcy Beeston. I'm a cancer genetic counselor, and I've been with Women and Infants Hospital since 2015. Today, I'm going to talk to you about hereditary cancer genetic testing in 2024. We're going to talk about the, excuse me, I'm going to try to reduce some of this. I'm going to talk about the what, the why, the who, the when, and the how of cancer genetic testing. We're going to talk about what I say to my patients when I initially meet with them, because most people, not all, but most come to a genetic counseling session without having any idea about what it's about, what the session is going to be like, or what the testing is like. So that's where we start. I'm going to share with you some reasons why you might want to consider genetic testing yourself. We're going to talk about what a genetic counseling session looks like, so that if you choose to meet with a genetic counselor, you'll have kind of an idea of what it looks like. And then I'm going to talk to you about a law that was put in place in 2008 to protect us all. I'm not forwarding. See, bear with me. There we go. This is a screenshot from a movie that came out in 2019 called Wine Country. I include this because it kind of represents how many people think about genetic testing when it is related to cancer. So the movie is about a group of friends who come together and they go off on a weekend vacation, but they all have their private struggles, and that comes out during the movie. This character had recently undergone genetic testing, and she gets a text in the middle of the weekend telling her result is ready. Her response is, I finally took the BRCA gene test and my results came back. I'm too afraid to call because I'm not ready to hear that I'm dying of breast cancer. This is the opposite of what genetic testing is for. There are two reasons to have cancer-related genetic testing. The only reason, if you're not affected with cancer, is to identify if you have increased risk for specific types of cancers so that we can then reduce that risk. So the goal is to prevent the dying part of cancer. The other reason to get cancer-related genetic testing, if you have had or in the past or have a current diagnosis of cancer, it can guide physicians for treatment, and also guide physicians in terms of what to do if you have a recurrence. So this is how I imagine many of my patients feel when they're thinking about genetic testing. It's a big, scary thing following you, and it's a lot of unknown. So I try to kind of dispel this from the beginning by using an analogy. So to kind of process what a gene does, think of a gene like it's just the name of a recipe, cooking. Our cells read the recipe and they produce a protein based on the instructions. The proteins produced by these genes work in different ways to help control cell growth. So they're actually protecting us from cancer. If you've ever heard BRCA talked about in the media, someone always says she's got the gene, or he's got the gene, and that makes it sound like this is something you don't want. Genetic testing is actually looking at our genetic code within these genes to determine if they're working right. Are they doing what they're supposed to? Are they protecting us from cancer? So a positive result is actually an indication that the person has inherited a dysfunctional copy of the gene. It's not working or doing its job. That is not a guarantee of cancer, but it is an indication that the person's chance of being diagnosed with cancer is higher than what we typically see. And so those screening recommendations that are appropriate for most people aren't appropriate for this individual with higher risk. And the information gives us the proof to support access to more screening. The other point I want to make, if there's a positive genetic test result, and you can see on the screen BRCA, that's just one gene known to be associated with hereditary breast, ovarian, prostate cancer in men, melanoma or skin cancer, and pancreatic cancer. But there are many, many other genes that also can be analyzed. BRCA is just the one that many people have heard of, so I just use that. So when an individual is positive, each of their children have a 50% chance of also being positive. There are the same risk for siblings. If you've inherited something from your mother's side of the family, then those individuals are at risk, and the same on father's side. So a positive genetic test result has a ripple effect in a family. Some individuals choose to get testing, some don't. The most important thing is that they get educated so that they can make their own choice. One thing I always say to my patients, the most important thing I want them to hear is that most cancer is not hereditary. 15 to 20% of breast cancers are hereditary. Around 20% of ovarian cancers. I believe it's around 20% of prostate cancers, 15 to 20% of colon cancers are hereditary, meaning something is being passed from generation to generation that causes increased risk. but the vast majority of cancer is caused by something the person has been exposed to in the environment. The goal of genetic testing is to address that extra risk by increasing specific types of surveillance. Maybe instead of just getting a mammogram once a year, the patient qualifies for mammogram and breast MRI staggered every 6 months. Maybe instead of getting a colonoscopy starting at age 50, you start screening even as early as 20 to 25 and get them more often. Some people can take risk-reducing medications, and in some cases, surgery is warranted if there are no effective screening methods. One example is risk for ovarian cancer. We don't have any effective, reliable screening methods for identifying early ovarian cancer. But when a woman is done having children, having her ovaries and fallopian tubes removed, if there's this increased risk identified through genetics, that reduces the risk for ovarian cancer by 96%. So now we're going to talk about what a genetic counseling session looks like. That family history tool is a valuable thing to be doing if you're thinking about meeting with a genetic counselor. Before we even set foot in a room with you, we will ask you to get that information. Information not only about your personal medical history, but your cancer family history is very important. So that's what happens before the appointment happens. At the appointment, I always start with my genetics 101, and that's just to try and help people understand what these genes are, how they function. We then review the personal medical and family history. This slide is just to give you an idea of what we're looking for in a family history or a personal history. The type of cancer, the age at diagnosis is relevant. For breast, uterine, colon, stomach cancer, any diagnosis 50 or younger is concerning. Male breast cancer, ovarian cancer, metastatic or prostate cancer that has spread, or pancreatic cancer at any age is concerning. Doesn't mean it's hereditary, but it's a red flag. For people who don't have a personal history of cancer, the family history becomes very important. We go out as far as first, second, third degree relatives. So that includes, of course, your parents, your siblings, your children, your aunts, uncles, cousins, grandparents, great aunts, even great grandparents. The history can go back that far to look for any clues as to whether there's a hereditary explanation. And this is an example of, I've changed this enough that you would never be able to guess who this actually is, but the basic story is here. My patient was this person right here, 72 years old, diagnosed with breast cancer. A 71-year-old with breast cancer alone, that's not concerning for a hereditary predisposition at all. But when you look at her family history, and in this chart, the circles are the women and the squares are the men. So this is her mother's side of the family. And if you look over here, she's got an aunt with breast cancer at 50 and a great aunt at an unknown age. So that raises concern for hereditary breast cancer. And the colon cancer spread across 3 generations, along with this pancreatic cancer, that raises concern for another hereditary condition called Lynch syndrome, LYNCH. That's just the last name of the guy who discovered the genes. So even if she weren't diagnosed with breast cancer, she qualifies for testing based on that family history. But if you look at the other side, she has a great aunt here who was diagnosed at a young age with breast cancer. So this patient underwent genetic testing, and her result was BRCA2 positive. So what this told us, first, it told us this is a very clear explanation for her breast cancer. And to give you perspective, average risk for breast cancer in women is 8 to 12%. So that's as low as we get to go. With BRCA2, the chance of a diagnosis of breast cancer jumps to 60% or higher. So it's a significant risk. Her result showed us that she had increased risk for ovarian cancer. So she had her ovaries removed, reducing the risk by 96%. Her son and daughter have a 50% chance of being positive. So the laboratory can just do a blood test to find out if they've inherited it, giving them access to extra screening. This BRCA2 variant was determined through testing of family members. She had two half-sisters over here, and one of them tested positive. So we know that it came from this side of the family. And we provided her with a family letter to help with communication. The letter is written to provide enough information that hopefully they will seek consultation with a genetic counselor to have a more in-depth conversation without scaring them so much they just don't want to deal with it. But that's our goal, is to do a testing of family members to try and reduce risk throughout the family. And I wanted to give you one more example of a family history. The patient in this case is this unaffected individual here, 41-year-old woman. She met criteria for genetic testing. And when I say she met criteria, I'm talking about national guidelines, and that just means her insurance company was very likely to cover the test. The reason she met criteria, you may be surprised because she obviously doesn't have a prostate, but prostate cancer is relevant for both men and women because it's associated with BRCA. And we know BRCA is associated with hereditary breast and ovarian cancer in women. This is particularly concerning because her grandfather died of prostate cancer. So more aggressive prostate cancers raise concern. And on her mother's side, the two cases of pancreatic cancer also met criteria. So that was two reasons for her to have genetic testing. Her result was actually negative. So that leaves us with no explanation for the family history. Based on what we see here, her breast screening could continue mammogram yearly. Her colonoscopy screening could start 45 or 50. Her risk for ovarian cancer is average, 1 to 1.5%. No need for pancreatic cancer screening based on this history. The good news was for her and for her children. We know that her children can't inherit something from her that she doesn't have. But there could be a hereditary explanation for some of this, that the patient got lucky and didn't inherit. So ultimately, I recommended genetic testing for her siblings, her maternal relatives, and her paternal relatives. Sometimes there's a hereditary explanation in a family, but there are people who test who are negative. Once we review the family history and determine whether or not genetic testing is warranted, we talk about the test itself. It's just a blood draw. It can be done the day of the appointment, or sometimes because the information it's a lot of information and it can be overwhelming. So some people choose to walk away without pursuing the test, take time to think about it, maybe talk to family members and get their perspectives, and that's fine. An appointment with a genetic counselor is not a commitment to have genetic testing. It's just a commitment to getting information to make your own decision. The test result is ready approximately 4 weeks after the blood is drawn. We talk about the possible test results and implications for family members. Often, people will come in thinking they're just coming to have their blood drawn. They really aren't nervous about it at all, expecting to have their blood drawn, come back another day to talk about the result. But it's much more complex than that, and the conversation is super important before committing to having your blood drawn. There are 3 possible results. A positive result leads to recommendations that are designed to reduce whatever risk is identified. So if you have increased risk for breast cancer, then extra breast screening. If you have increased risk for prostate cancer, then prostate screening at an earlier age and potentially more often would be recommended. Increased risk for colon cancer, colonoscopies at a younger age and more often than would otherwise be recommended. So you kind of get the idea. A negative result, unless someone else in the family has had a positive result, a negative result leaves the family history unexplained. And then we use that history and make recommendations just based on that. There's a possibility of an inconclusive result. We call that a variant of uncertain significance. And that's a genetic change that can be identified in any of these genes that the laboratory has either never seen before, maybe they've only seen it in a few families, and they just don't have enough evidence to say with absolute certainty that it's harmless. So they report those, but we don't act on them until we get more information. Something I wanted to talk about before and forgot, so I want to back up a little bit. I just want to make the point that this testing is not research, it's diagnostic. There's enough, there are decades actually of research behind this testing. So when I say it's diagnostic, that means if we have a positive result, we know that there's increased risk and we know that the person qualifies for the extra screening that I've mentioned. The age, if there's a positive result in a family, the age when we recommend genetic testing for other family members differs by gene. BRCA2 and also BRCA1 is an example of the breast, ovarian, prostate cancer in men. Medical management changes in women at age 25. So that's when we recommend genetic testing for them. Medical management changes in men at age 35. So that's the ideal age for genetic testing. CHEK2 is a gene that's associated with hereditary breast and colon cancer. The ages to start or to undergo genetic testing differs, as you can see here. I want to talk briefly about this law I mentioned at the beginning. The Genetic Information Non-Discrimination Act was passed in 2008. It prevents medical insurance companies and employers from using a positive result to raise premiums, deny coverage, or discriminate. This law is not in place with regard to life insurance, long-term care, and disability. So if you are considering genetic testing, this is something to look into. If you don't have a life insurance policy in place and you want one, I would get it before pursuing genetic testing. This law prevents medical insurance companies from using the information as pre-existing, but not life insurance, long-term care, and disability. The cost of the test. So this is something that even 2015, when I started, the test was thousands of dollars if it wasn't covered. Thankfully, the technology has greatly improved and the cost has come down significantly. The laboratory that we use, if a person doesn't have insurance, the maximum cost of this test is $250. The vast majority of our patients pay less than $100. So I'm hoping I've dumped a lot of information on you, and I'm hoping that you don't feel quite like this if you choose to pursue genetic testing, but instead more like this. And I have put my contact information in the chat, but here it is again. The number 430-7274, that's my personal line at work. I can't give you medical advice by phone, but I can tell you if your family history is concerning and if I think it would benefit you to consider genetic testing. So feel free to reach out to me if you'd like to make an appointment. That's the number there as well. I can receive emails. Again, I can't give medical advice by email, but I can return a call, reach out to you so we can talk briefly on the phone.
Thank you so much, Marcy. That such great information. Can you clarify a couple of things? I think I have two questions.
And I have one.
What does BRCA stand for? So people...
that's a good question. Breast cancer, it was initially identified in association with hereditary breast cancer, and over time, we learned that there's this association with hereditary breast, ovarian, prostate cancer in men, melanoma, and pancreatic. So it's more than breast cancer. But that's...
Thank you so much, because I didn't want people to, oftentimes, this is my second question, we get our testing done through these different testing sites to find out our genetic makeup, and we think we can rely on that. Can you speak to, like the 23andMe or the other 8 sites? Can you speak to that?
Yeah, that's, those are fun things to do. I really would hesitate to encourage anybody to get that information and use medical information that comes from those. And I'll give you an example. 23andMe does BRCA testing, but this may have changed in the last year or two, but I'm not sure. So bear with me. The last I understood, they analyzed 3 genetic changes in the 2 genes that are common in Eastern European Jewish families. So that's 3 genetic changes in BRCA1 and 2 out of thousands. So we've had patients who came to us and said, I've already had BRCA testing, I'm negative. Not if it was done through 23andMe, or I think you can get the same kind of information from some of the other companies. The other thing to understand too, there are 13 genes that help explain hereditary breast cancer. BRCA1 and BRCA2 are 2 of those genes. So talking to someone who can look at your family history and make a recommendation to make sure it's a thorough and comprehensive test is very important. The test that we talk about routinely is 91 genes. And that test, I know it's a lot. The 91 gene panel includes everything currently known to be associated with hereditary breast, ovarian, colon, stomach, pancreatic, kidney, uterine, melanoma, prostate cancer, and some other more rare cancer types. So doing the direct-to-consumer testing, it's a fun thing to do. That's what I would say, but it's not something that I would recommend when you're thinking about this kind of information.
Thank you so very much, Pastor Pam.
Yeah, because I'm thinking of doing the genetic counseling, and if I take this testing, and it's positive, would you recommend that I pass this on to my children? And
information?
Excuse me?
You mean pass the information on to your children?
Pass the information where they should have BRCA testing as well.
Yes. And I think I interrupted you. Did you have another question?
No, that was it. That was
okay. So yes, that's really, really important. If your test result is positive, your children have the right to decide to move forward themselves or not. And some people choose not to. But I think if I was sitting with you and saying you're positive and your children have a 50% chance of being positive, the first thing I would want to know is how old are your children? Right. The earliest we test children is age 18 with very few exceptions. But I meet with younger individuals I have in the past when the parent is positive. It's more a meeting to allow them to ask questions. It's really up to the parents if we're talking about minors. But yes, absolutely. We strongly encourage sharing information, not only with children, but siblings and aunts, uncles, parents.
Thank you.
Mhm.
Because I was just thinking of that. And since then, we've been having family conversations, and come to find out, my father's siblings, and they come to find out it all comes from my father's side, that the men have prostate and the women have breast. So I am passing all this information down to my children now, but genetic testing seems to be more accurate than just saying this is what is going on in our family.
Right. And the other benefit, if something is identified, if you're positive, and your test explains your diagnosis and family history, then your children, they could be negative. So if there's a strong explanation for, you said you had breast cancer, correct? Am I
Yes.
remembering that?
Yes.
If your result is positive and your son or daughter is negative, then we can say they don't have the risk associated with the family history. So your daughter's risk might be average, 8 to 12%. You can identify the individuals in the family who are actually at risk and give them access to extra screening and avoid putting that burden on people who don't need it.
Very good. And one more question. It might be stupid, but does it skip generations?
No stupid questions. And I have answered that question many, many times. No, it doesn't skip generations.
Okay.
The cancer can sometimes skip generations,
Yes.
but not the predisposition for cancer. So I had a patient who, she had a new diagnosis of cancer. I met with her initially, and she didn't even meet criteria, but she had a very small family she had on her father's side an uncle and one cousin. So very small family, so not very significant history. She was BRCA positive, and we learned through testing of family members that she had inherited it from her father's father. So they both lived their lives with no cancer. The risk to men is lower than for women. So it wasn't shocking to see when you realize it came from her grandfather's line. So it looked like it skipped generations, but it didn't.
Yeah. Very good. Thank you. Thank you so much.
When I say that this has been such a powerful presentation. Thank you, Dr. Fabius. Thank you, Marcy. I think about my family, the elders in my family who had surgeries later in life. Dr. Fabius, if I had known then some of the things I would have done differently. And Marcy, now I can have this conversation with my children and my nieces and nephews about the information. And as I was sitting here thinking about some of the elders in my family who walk with limps, who think they can just shake it off, they really should go to their doctors.
Yeah.
We should be talking with our families about this instance about, cancers, ovarian, uterine, those things that can be, we can treat them early if we know that as you say on your slide, knowledge is power and hope. My eyes are filled with tears because I'm thinking, wow, maybe some of the things we could have avoided, but this is the right time to get this information out. And we're hoping that everyone who has listened to these talks and watched these videos, take this information and do something. Talk to your families, talk to your elders, talk to your siblings and your your children about this information. Knowledge is power. I'm going to be reaching out to you too, because we're going to do some genetic testing.
Please
So,
do.
Dr. Fabius, we certainly thank you. And for those of us who are older and we've heard the doctor, don't think we can diagnose it ourselves. And we do not recommend using commercial sites to substitute for physicians' work. These physicians have studied and they know their stuff. How about that? And we're very grateful to you, Dr. Fabius, to you, Marcy, for sharing this information. To you, Reverend Farley, being the Vice President of the Ministers Alliance. Thank you so very much. To
May
you,
I ask Dr. Fabius one question, please?
Sure.
We know that now. We know that knowledge is power, and we also heard. That's what I want the clarity. That canned food is associated with cancer. Is it true? Food in the can.
Canned food is associated.
Yeah.
So I'm not going to talk for any of the doctors. They can answer that question.
Yeah, that's what I'm trying to ask the doctor.
Okay.
Will you please help us?
No, to my knowledge, that's not an associated risk. They're provided everything's stored properly, and you're eating it appropriately. There shouldn't be anything there that would cause or be predispose you to cancer risk.
All right, thank you.
It's a great question.
The risks, there are many, in the environment. So, number one, obviously smoking. We now know that even, alcohol, if it's consumed frequently, is a risk for colon cancer. So there are risks out there. If again, I would advise anyone who wants to know them to talk in detail with their physician about their particular, habits, what they smoke and drink, etc., to get the input of their physician.
Well, that was an eye opener for me. Thank you.
Wow. I mean, the other, some cultures like to eat a lot of charred food, particularly like Japanese populations enjoy charred barbecued food. I mean, we know that that's also a risk for esophageal cancer in that population. So again, providing your particular diet and the nuances of that diet to your physician, in discussion could lead you to be more knowledgeable about the risks.
I just learned something.
Knowledge is power. Wow. Talk to your doctors. And I thank you, Reverend Farley, for bringing up those questions. We really wanted to make sure that these conversations would help debunk some of our urban legends, some of the things that we think that we know. We really want to talk to the contact matter experts in these matters. And so thank you for asking the question. Again, thank you, Dr. Fabius, for being with us. Thank you, Marcy. Thank you all who have been watching, those who will watch. Again, if you need any information, contact information, please reach out to the Ministers Alliance. We'll be happy to help and connect you because we really do want to advance this conversation as we continue on. We'll be moving towards screenings and talking about survivorship because, as Dr. Fabius told us earlier, and Marcy told us, that early detection is really the key to survival and curing those cancers that can be cured. And so we certainly thank you for joining us, and we will have our next conversation tomorrow at St. Elizabeth's home. We're very excited as well. And so please continue to join us and participate in these wonderful conversations. And we appreciate you all. Thank you very much.
Thank you.
Thank you. Thanks, everyone.
Thank you.